I'm going to be talking about health workforce issues, especially in the context of universal health coverage. I believe that Dr. Sundaraman in a previous presentation already covered this theme extensively. So I'm going to try and take a slightly different spin on it and talk about the issue of diversity or pluralism in the context of the health workforce. Pluralism is a term which is related to our anthropologist colleagues, but now I think it's gaining increasing recognition in the field of public health and policy as well. So I just highlight how this is particularly relevant for us. The main theme of what I'm trying to put across is that we have a very diverse workforce, and that diversity necessitates differential handling for different aspects, different segments of the workforce. You can't look at the workforce as one entity, and in fact, there are radically different approaches which need to be taken for different parts of the workforce. This is the overall structure of my presentation. I'm just going to start with a brief overview of what I consider to be the crucial context, which is that of mixed health systems, or to be more specific, mixed health systems syndrome. So I'll go into this in a little more detail. I'll touch on the issues of workforce diversity. And given this particular combination of workforce diversity and a context of mixed health system syndrome, we come across certain very specific challenges. And I'll outline some of those challenges for taking the workforce forward. I'll then go on to outline some governance questions, and then finally I'll end with a brief summary on the road to UHC. And I hope I can fit all this in now 13 minutes and 20 seconds, but I'll do my best. So just to start with this concept of mixed health systems. But before that, I want to outline, again, referring back to the recommendations of the expert group on universal health coverage. These are some of, this is an overview of the goals they have put up for human health. The ambitious goal of achieving WHO's norm of 23 health workers per 10,000 population, and specifically here of raising the number of nurses and ANMs to a ratio of 3 per doctor, as opposed to the current ratio, which is approximately 1.5 by 2025. Doubling the number of community health workers, introducing rural healthcare practitioners or mid-level practitioners, whatever you want to call them, and integrating and bringing bridge courses for Ayush professionals, and also ensuring equitable availability of allied health professionals. So you'll see here there's already a fair focus on the non-doctor segments of the workforce, which is kind of the focus of this presentation as well, and I'm going to continue that emphasis. The expert group recommendations also outlined a roadmap entailing training, knowledge management, and regulatory systems for enhancing HRH capacity. However, before we can think about implementing and achieving some of those goals of universal coverage, I think it becomes relevant to think about the existing state of affairs in our country. And it is comparable, although probably an extreme example of what has now been known to be mixed health systems syndrome. So I'll just go into this in a little more detail. So Oxfam defines mixed health systems not only as systems having a combination of the public and private, but specifically of systems entailing centrally planned government health services that operate side by side with private markets for similar or complementary products and services. And qualifying that a little bit further, these health systems, these many low and middle income country health systems with mixed economies, with mixed income groups, are characterized by this particular syndrome when you look at health systems as well. There's extreme diversity in healthcare provision. That's not necessarily a problem. That's a strength as well. But the other aspects are fairly problematic: dominant, poorly organized private markets, compromised public services, and a blurring of the public-private distinction, which is not out of design but out of accident usually. And that refers to the kind of informal payments that takes place in the public sector and the kind of formal and informal public-private partnerships that get formed. So moving on from there, I'd just like you to focus specifically on the first element of the mixed health system syndrome, the diversity in healthcare provision, because that's the main subject of my presentation. But also understand the fact and recognize the fact that this diversity exists in the context of a broader context of compromised markets and compromised public systems. So market failure and governance failure underpin this diversity, and the diverse health sector functions in this particular context. This is just a quick snapshot, some images of what we know our health system to be like, just to illustrate the diversity. I don't think I need to go into any of those. There's a private practitioner, a traditional practitioner, a government clinic, potentially an OT in a big corporate hospital. But this sort of extreme diversity also highlights what some commentators have questioned. Is the Indian health system a system or is it a non-system? The Indian medical domain is an eclectic non-system of knowledge and practices deriving from the continuous interplay of indigenous and introduced traditions. This is from Helen Lambert. So moving on to some of those elements of workforce diversity. So in the first place, when we talk about a diverse workforce, it's important to recognize that the workforce is diverse, but it's diverse in diverse ways. So there's a kind of a diversity squared. There's a continuum from the public to the private in the healthcare provision, system of healthcare provision. Health workers range from highly formalized to highly informal legitimacy that has been conferred on them. Systems of knowledge range from the Western to the indigenous. And increasingly, there's a recognition of the non-professional cadres, which have always existed, but now they're increasingly being mainstreamed into the regular health system. So coming to this issue of mainstreaming, I just want to highlight that this is a potentially useful way of imagining or visioning diversity in the Indian healthcare sector. It's not something that we can visualize along one axis, but we need multiple axes to look at this issue of diversity. So you've got, on the left-hand side of this diagram, you've got the professionalized, the allopathic, and the formal healthcare providers. So if you're looking at your, the traditional image of an allopathic doctor, then they would fall on the left of the continuum. And on the right side, you have what have generally been associated with the non-mainstream. So these are the alternative segments, the informal providers, the non-allopathic providers, and the non-professionalized cadres of the health workforce. But however, when I use the word mainstream and non-mainstream here, I just want to qualify that this is mainstream. The use of the word here is mainstream according to, say, government speak or according to public sector speak. But when you look at how markets actually function, health markets actually function, or how communities actually envision or utilize different types of healthcare providers, we may actually invert that. And we may find that it is this alternative sector that's actually the mainstream in the context when we look at the context of markets and communities. So this is a free listing. I thought a fairly comprehensive listing, although there will be additional groups who fall into, who can be accommodated in these different categories. But generally, we can look at physicians, nurses, Ayush practitioners. You have this new category of mid-level or rural healthcare practitioners, allied health professionals. Very importantly, non-codified traditional complementary and alternative providers. So these are people who are not part of the Ayush system, but may exist through other more traditional forms of continuation of knowledge and education. Informal providers are a huge sector in India, potentially more than the formal providers. And here I would refer to informal providers who are not necessarily part of the non-codified traditions, but may generally be untrained in most respects. Frontline health workers, community health workers, are a very crucial group, and especially when we look at universal coverage, and I think some of the subsequent presentations will also focus on this group. And then this very crucial group of household carers, which I think probably, there was a presentation earlier by Kanno Tage, and he emphasized the importance of women and household healthcare practices, and the fact that we have this huge productive segment of the health workforce working in homes, looking after children, looking after the elderly, but we don't really recognize this as a productive sector of work. And I think that should change. But how we do it is a completely different cup of tea. So now we've outlined the diversity and we outlined the context of mixed health systems. So this gives rise to this particular combination of diversity and the kind of failing markets and failing health systems gives rise to a particular set of challenges, which I like to call the triple challenge. So when we look at developing, taking forward, furthering, stewarding the health workforce, we come across three issues which are complementary, but sometimes the policy directions that they indicate are not always convergent. So sometimes we tend to focus on adequacy and quality, but we miss out on the welfare. The crucial aspect that this is a labor, this is an entire segment of the workforce, and we miss out on the kind of welfare aspects in that, which is absolutely crucial. So I just want to give you a quick snapshot of what I mean by adequacy challenge, the quality challenge, and the welfare challenge. So adequacy challenges would include considering issues such as, is the workforce proportionate to population needs? Is it rationally distributed? Is it geographically distributed appropriately? Is it not subject to excessive drain to other countries and from rural areas to urban areas? And is it equitably accessible? The quality challenge addresses issues such as quality of education, continuing education, presence of regulations, the actual quality of practice, the ethics of practice. So a whole range, a gamut of challenges which encompass the issue of the fundamental issue of quality. And also very crucially, accountability to communities. Are there mechanisms through which providers can be accountable to communities? And then the welfare challenge, of course, always starts with the argument around remuneration, but it goes much beyond that, and it's important also to look at employment benefits and security, professional development and advancement, accountability within the workplace, promotion and transfer, and also right down to basic safety issues, harassment, protection from sexual harassment, gender equality in the workplace, and a range of other welfare-related issues. So given that particular framework, I've drawn up this table. This is not based on any rigorous evaluation or approach, but it's more to indicate, to give you a specific sense of how the different challenges apply differently to different segments of the workforce. So, I mean, you can see the left-hand column is the health worker categories that I described earlier. And then we've got adequacy, quality, and welfare. So I don't want to take you through the whole list. I just want to highlight here that you see that the challenges are extreme when we talk about adequacy of the upper echelons of the workforce. So physicians and nurses, getting them to rural areas is a particularly wicked problem. When we talk about welfare, then you look further down the list at the lower echelons of health workers, but also some areas like nurses and Ayush also, it's very important to recognize that welfare is a crucial issue for them as well. Quality challenges are, again, you can see a general continuum from top to bottom. So again, to highlight that kind of inverse relationship between the adequacy challenge on the one hand, which moves from the bottom to the top, and you have the quality and welfare challenges which move from the top to the bottom. This is just generally speaking, but it gives you a sense of how differential policy approaches are required for the different cadres of the workforce. So moving on to some governance questions. This is from a WHO paper. So when we talk about governance, what do we mean by workforce governance? Is it a separate domain? And yes, I think this was quite a persuasive framework developed by WHO in the context of nursing governance. So we need to look separately at leadership and regulation, at education and development, and finally at deployment and utilization. And these cogs move together. So again, this is a kind of a mapping of the governance architecture for these different cadres of workers, and we find that they are very differently governed. And I've listed the three different aspects of governance over there. Also draw your attention to the fourth column on the extent of self-governance of the profession and the extent of organization of the profession. So again, just highlighting some crucial things here. Nurses are not entirely self-governed. Very often they are run by they are governed through a directorate structure which is dominated by other professions. Ayush, on the other hand, has its own department and does govern itself. And for example, another instance such as the mid-level practitioner is not really clear because there's a new cadre who is going to actually regulate and who is going to lead this new cadre. Then when you come to the lower kind of forms of, or rather the kind of lower echelons, then it comes, we come across phenomena such as deployment and utilization of the non-codified segments. It's been found that very often they work for no pay. They work under a, they work part-time or they work for exchange of goods. When it comes to community health workers, there are several question marks around whether they are regulated by PRI and what are the actual systems in place for their education and development. So just to take away some of those key issues, and I'm just going to conclude in a couple of slides, we can conclude with some crucial takeaway lessons here. Poor recognition of unskilled primary care, which is a very crucial element of the workforce. Poor recognition of the continuity between household informal and formal health practices. Directorate-led governance is top-heavy, reinforces doctor dominance over the other segments of the workforce. A potential alternative is, as in Amendment 73 and 74, enhanced roles of panchayats and local bodies. Little attention to workforce welfare compared to the other aspects. especially in the lower echelons of the workforce. Increasingly, even new deployments are being seen in the contracting mode, and contracting generally tends to give very little attention to welfare and benefits. A widespread disagreement on the legitimacy of certain segments of the workforce, including the TCAM and the informal sectors. Low capacity for education. And crucially, something that's, I think, not very well understood is low capacity for governance. So we don't actually know how to run large systems. So just to conclude with a final point of fisheye lens, what I like to call a very broad take on the road to universal health coverage. We need to be attentive not only to health goals, but also to stakeholder needs. And in that process, we need to ensure access, quality and performance, as well as welfare of providers. We need comprehensive multi-level reform, changes in policy design and oversight, creation of structures for training and deployment, and also continued stewardship. After people have been deployed, there needs to be a continued system of management. And in order to do this, we need to reorient the way we think and the way we conceptualize the health system. There needs to be a political and cultural transformation in which the roles of all providers are respected, even while addressing irrational practices. So this is the actual last slide. I'm going to conclude with just 4 salient points, which I think should be taken away. We exist in a condition of heterogeneous health service sector, entrenched in failing markets and eroding public sector, and this raises particular challenges for the achievement of universal health coverage. In order to address this challenge, we need to embrace a broad conceptualization of a diverse workforce with varying utilities. They don't always have the same function. Our goal should be to achieve adequacy of and optimal roles for different providers in a mixed health service ecosystem. We need to work with horses for courses, varying policy attention based on type and degree of challenge posed by the segment of the workforce. And we need equivalent attention to elements of workforce governance, different elements of workforce governance, including leadership and regulation, education and deployment. Close here with thanks.
Thank you, Kabir, for that very comprehensive presentation and taking us through the diversity, the plurality, and the complexity of HRH. And having been an HRH researcher and policy, a person interested in that, I can tell you that if you start looking at the evidence when you are in positions or sitting around the policy table, there are many of these issues where we are still, looking at opinions and not really getting hardcore evidence. And I think it's very good that you challenged the group that this is the way ahead, but it's a long way ahead. What I'm planning to do is that rather than having a discussion after each presentation, I thought just to make it a little interactive, I'm going to allow just 2 questions, but we may not answer them. We'll answer all the questions at the end. But if anybody feels there are two people who feel they really need to ask or make a presentation or say something to Kabir, please put up your hands. And I just take 2, and I won't ask Kabir to answer it now. He can think about it, and we'll come back to it. But the first 2, was there something that you really felt you wanted to add to this very interesting presentation? If not, yes, okay. Rupa.
I always see a very broad overview when it comes to the mixed health system. I want to know if there are any studies on the ground which actually work with a local area with a couple of doctors from homeopathy, allopathy, yoga, Unani, and what we club as the Ayush. Is there a working model? Because I constantly feel that this is seen as a deterrent, and actually it could be a potential richness.
Considering the plurality of the workforce, I would like to ask one specific question. Whether we need to go for multitasking, that is few persons knowing all the jobs, or single tasking because of the plurality in order to achieve UHC, universal health coverage.